Welcome to the CMSC's virtual poster tour. This poster is titled Determining the Effect of Early versus Later Diagnosis of Multiple Sclerosis on Long-Term Prognosis in a Real-World Setting. Our presenter today is Zachariah. Dr. Zachariah is a resident in the Department of Neurology and the Neuroscience Institute at Allegheny General Hospital in Pittsburgh. Welcome, Dr. Zachariah. Your poster topic is a bit controversial because we've always heard that patients who are diagnosed earlier have better outcomes. What are your thoughts on that?
Exactly. So although it is true that patients who are diagnosed and treated early, especially with high efficacy disease-modifying therapy, have better prognosis. However, the data is usually derived from matched cohorts, typically from a well-selected patients, usually in the previous CIS trials. In these matched group trials, earlier treatment has been seen beneficial, but this is not seen in our study. So the benefit of early versus late diagnosis leading to earlier treatment can be offset by various other variables. The likely difference between our findings and these previous trials is likely due to the differences in patient ascertainment. In our study, which is a retrospective observational study, in the real-world setting, we found that patients tend to have delay of many months prior to diagnosis, with usually a second clinical event leading up to the first office visit. This is likely the reason for our varied conclusion.
Your study looked at data retrospectively between 1989 and 2005, and this was prior to the availability of most DMTs. Is there a reason why you looked at natural history rather than a population that was on treatment?
So we began our EDSS measurements in 1989 on newly diagnosed patients, and the effects of the treatment with DMTs was only one of the many variables that we studied in this analysis. We note that approximately 90% of the patients studied were diagnosed after the availability of DMT. And yes, this is actually one of our limitations of the study. Our data does precede the new DMT era. And if we need to replicate this study with new DMTs in play. However, a prospective study design might create a bias towards including MS patients at higher risk of decline. Such a group of patients might also have a higher modifiable event rate. We found no significant difference between the early presenting group and the late presenting group in terms of age, gender, EDSS milestone reach, and other characteristics of initial attack. Of all the clinical factors we examined for association with early presenting versus late presentation, the only thing that we found was high early relapse frequency. The high early relapse frequency was associated with a higher likelihood of belonging to the EP or the early presenting group with a p-value of 0.014. We therefore propose a complex interplay of many risk factors that can lead to early diagnosis and treatment, though we could only identify one such factor, early high relapse frequency. Also, the benefit of this early treatment may have been offset by this and other factors.
You have a figure that shows a correlation between presenting symptoms and EDSS scores. Can you discuss that a little bit?
Yeah, so that figure really depicts the number of patients presenting with initial symptoms by anatomical regions. So what we did, we looked at the outcomes of these patients at 10-year and 15-year, and these measurements across all presentation. However, it only showed a marginal but a significantly worse outcome for transverse myelitis and brain symptoms rather than motor onset sensory or optic neuritis. There's no difference between the early presenting group and the late presenting group in terms of types of CIS symptoms.
And finally, in your conclusion, you say that you recommend a nuanced approach to the idea of early diagnosis and treatment lead to better outcomes. Can you discuss that?
Yeah, so our results indicate that a nuanced approach should be applied for the general rule of early treatment equals better long-term outcome. Factors relating to disease severity may push more severe patients to earlier treatment, and the long-term benefit might seem less apparent in this enriched population. So our findings of a high early relapse rate in the early presenting groups did suggest identification of a high-risk group, But other traditional risk factors such as male gender, poor recovery from initial attack, motor system involvement were not overrepresented in this EP or the early presenting group. Early presentation lead to early diagnosis and treatment on our cohort, yet this did not improve the long-term prognosis in our patients. Perhaps a combination of the known risk factors of early attack frequency and other identifiable risks were offset by the early treatment in our EP group. Case ascertainment issues may explain our results, and patients with prominent classic CIA symptoms might seek medical attention earlier than the average MS patient.
Great. Thank you very much. It was an interesting discussion. Thanks a lot.
Thank you.